Yeah, I'm going to be a little provocative. I'm going to bring up the issue with intratendinous injections. It's become very popular worldwide to inject different substances in tendons. But what do you think? Is there enough science backing up that we inject different substances, factors in tendons? Do we know what this tendon is missing? Has it been shown that there is a lack of certain growth factors? Can we again legally back up that we inject growth factors in tendons? What's your opinion?
That's a big fat nothing from the audience. It's all right. I'm sure you won't insist saying something controversial.
I'm not sure about that. I'd like to fire a shot back across the ship of the interventionalists from the physio side of things and say that it doesn't matter really from a rehab perspective what's been done injection-wise if they're given a good opportunity to rehab appropriately for their chosen activity. We tend to get pretty good outcomes no matter what's been stuck near, in, out or around the tendon.
I would definitely disagree on that part, because the most complicated cases I see are the ones that have cortisone injected in the tendons. They quite often end up with a necrotic region that does not respond at all to other treatments. So I have a little different opinion on that.
I think probably separating the corticosteroid from the things that are meant to regenerate versus the things that are meant to, I guess, calm the tendon down is perhaps your point.
Jack Bader, another comment, not trying to be controversial here, I'm trying to bring us all together, and I wanted to highlight something that I consistently notice is that people's opinions and observations are strongly driven by the patient population that walks through their door. And we need to remember that if we're a shoulder specialist or an Achilles specialist, a physio or a surgeon, we're the specialists in the field, and we're probably seeing a subpopulation of people who fail regular management and fail to resolve with no treatments or fail to resolve with despite the treatments that they get. So I just like us all to keep that in mind, but I'll try and think of something controversial for the next section.
And I think one of the things that's was highlighted to me in this two-day conference is just how much of our understanding is perhaps being extrapolated from the rotator cuff, and the application of that to our lower limb tendons and perhaps our higher energy storage tendons. And I think we have to be careful about saying a tendon is a tendon is a tendon when that's actually probably not true. I mean, I think those of us that specialise in lower limb tendinopathy won't go near a shoulder impedus, and I think the reverse is probably true, and I think that really probably reflects that they're actually quite different in their presentation. So we have to do more research in the non-shoulder tendons, I think, to help us understand the differences between them.
No basic scientists having any opinions about growth factors in tendons? Should we use it in patients?
But from Germany. We did a lot of work about the effect of growth factors on the cells which were isolated from the human biopsies. And based on these results, I would say yes, there's a potential that growth factors stimulate the biological potential of these cells. However, the clinical application is still in the far distance. And when we are looking at the results which are obtained from the PRP studies, where they use the autologous blood preparations, they are not very promising, and they do not show that the PRP injection really has a benefit on tendinopathy. So therefore, I think there's a lot of more work necessary, and yeah, it will take some time until these therapies will be in the clinic.
Robert Tendinopathy from the Erasmus Medical Centre in that's just what I would like to say. And I think we have to differentiate between the current clinics and the research we are performing. Because I think from a clinical point of view, there's insufficient evidence or even evidence against the use of regenerative injections. So, and for the research, I think it's really interesting that we can continue with that.
Could we suggest that there might be a consensus here that intratendinous injections are perhaps not positive for tendinopathy? Does anybody want to say, have a strong opinion that that's not the case? That'd be a wonderful outcome from here. I'd do a little jig to celebrate this. Who wants to have an opinion that there is still a place for intratendinous injections that are regenerative in inverted commas? Yeah, excluding stem cells, Roger. Just think. You can have a say next, but in terms of the non-cell based, let's go with growth factor based perspectives.
Yeah. Well, there has been many attempts for many years of having growth factors locally delivered. They did not go to clinics because they were not convincing. But when you have a mixture of growth factors, like you have in platelets, it's a mixture of about a dozen of them plus inhibitors, so nobody knows exactly if what is being delivered because they're really destroyed. So I don't think that it's a possibility that is still open to improve much of injection of proteins in a very acute injury. But if you inject it, whether you inject it intra or extra, because of this breakage, there is an exchange. So I don't think that will make a big difference. And I know with the experiments we have already that it is peri-tendinous is much enough. We don't always have to go inside because it will eventually penetrate. It's like the blood-brain barrier, where you have when you have some lesions, then there is an exchange. So I don't think this separation is making too much sense in real pathology or acute or even in chronic.
So what you mean is that there is a communication between the outside and the inside, even in a non-ruptured tendon?
Well, it's micro-ruptures, so there is some of the...
That is being questioned, whether there are micro-ruptures or not.
Well...
Roger, do you want to comment? Next.
I can make a brief comment about injections, because I would say that a blanket ban on intratendinous injections is an odd state, because it depends on what you're injecting, in particular the volume. I think it can be large volumes inside the tendon can be very damaging, and also the state of the tendon matrix, like you say. So if you don't have a space to inject anything, if there's not destruction sufficient to take a volume of fluid, then I think it is potentially very damaging. So, and I think that's probably with these chronic fibrosis tendons, it's very difficult to inject anything into them, and I suspect that causes damage. It certainly does in our own tendons.
But Roger, do you think there is science enough backing up injections into the tendon? Whatever you inject, I mean, even stem cells, is there science enough for doctors to start injecting stem cells in tendons?
I mean, I think on the human side, one has to be a lot more cautious. I agree. The experimental studies that have been done in the majority of animal models would support that some treatments are effective. But of course, that's, although I say that there are some animal models that are closer to humans, there are still differences. So I think ultimately it's just a way of getting your treatment to the organ, and if it will go in from the outside, then that's fine, then I would definitely be advocating it that it's delivered outside the tendon, not inside. But at the moment, we have, I think with the size of the tendons I'm dealing with, they're big and it's difficult to get things to penetrate from the outside, and so we have to resort to injections. If there are other more elegant ways of delivering things, that's why we looked at regional perfusion and things like that, that would be much less damaging to the tendon. And it's when it's getting used inappropriately, I think that's the major problem.
So that comes back to that appropriate clinical decision making. We have one upstairs first and then
So Patrick Wheeler for Monash, not for I think it would be great if we knew the answers. I think what we're dealing with is uncertainty. We we haven't got an absolute definition of tendinopathy, and actually are we looking at a subgroup, a wide group of conditions, some of which may respond to different treatments. Dylan talked earlier on about an intratendinous tear treated with dextrose. Is that part of a tendinopathy spectrum, or is that a different condition? If it's part of a tendinopathy condition, then yeah, there are patients that Dylan and his team have treated with an intratendinous injection, which have done very well. Now, there isn't great evidence for it at the moment, and that's part of where we are. We've all seen the PRP evidence over the last few years in particular fall away from where it would be great if we had an effective treatment of tendinopathy, and I'm not sure that much of the evidence for PRP recently shows any great effect of it. But I think we probably are a way away from saying that no injections into tendon are helpful. I think we just don't know.
It's difficult to come to a consensus statement as you hear, but would it be fair to summarize it like this, that with the scientific knowledge we have today, we are not yet ready for intratendinous injections? We haven't excluded the later possibility.
Concerning that, we can't agree on the definition of pathology, so we're not going to agree on the treatment, because the treatment is not only how the disease is progressing and how it's happening to tendons, we still don't understand that. So we need to know that to be able to target pathology and hit it on the head and treat it. In terms of using growth factors, there's also the problem of which growth factor you're going to use. There's so many of them, there's so many isomers, hundreds of factors, and by which means you're going to deliver them to the tendons. So I agree with you, there's no evidence in the evidence that suggests either way.
I'd just like to make, Margaret Smith, Sydney, I'd just like to make two comments. The first is that tendinopathy is a longitudinal disease, so it starts out with a small amount of inflammation and then goes through a whole lot of phases before you get to a chronic tendinopathy. And I know this because we've got animal models which we induce with surgery, and we can actually see what happens over time, up to a year. The model we have has stress-deprived and overstressed regions. The overstressed regions tend to go back to normal, the stress-deprived regions don't. Both end up with chondroid metaplasia within them. We've treated them with stem cells, injected into the lesion that we have, so we actually have a space to inject into, and we can virtually get the stress-deprived regions back to normal. The other ones are going back to normal by themselves. So the advantage of stem cells over giving something like a growth factor injection is that you are actually giving all the growth factors. The cells respond to the matrix they're in and they normalise it. So they will produce the growth factors required to normalise the matrix. At least that's the theory that we have and what seems to be happening in Rogers horses. So I think there is a role for cell therapies. We have only tried bone marrow-derived cultured stem cells, so I have no idea what the fat stromal fractions do. I don't know if they'll do the same thing. I can tell you that human-derived cultured stem cells are extremely variable compared to the sheep ones that we use. So I don't think you'll get the same significant effect because we have such a small standard deviation in the sheep.
And the work that your group do are fantastic when we run into both the animal model issue plus the surgical intervention issue, whereas our human overuse tendinopathy is a little bit different. But we have to start with these models because we can't do it in human tendons. We've got about 2 minutes to finish, so pressing questions or pressing comments. Do you want to make it?
Hi, I'm Hazel Sweet. So basic scientists and other engineers. That's a different viewpoint, but I've been listening for a while. Do you know what? I think the lack of consensus might be a good thing. I've been thinking a bit more about, well, certainly when I started looking at tendon, I kind of came in from an engineering perspective, and I'll really echo Mark's points. It's an awesome material from an engineering perspective, and I was very interested in understanding how tendon works and trying to look structurally at how we get the sort of functions we see. And I thought I was going to be able to answer this question reasonably easily and spend a couple of years at work out how tendon functions. And a few years later, I'm not really how many, I've actually just got more and more problems. And all I seem to find is, of course, the functions we expect our tendons to carry out are very different. Structurally, they're very different. Their response to treatment are very different. All of these things are really part of trying to understand it, to get a consensus when we're actually trying to look at so many different tissues. I think perhaps the consensus is we can't think of tendon as one tissue with one solution and one way to look at it.
I think that's a damn wonderful way to finish.